Thank you, everybody, for joining me on my webinar today. The title of this presentation is From Zero to Hero, Soft Tissue Solutions to Implant Aesthetic Dilemmas. And what I wanted to go through today is kind of outline some of the key factors that it takes, to make sure that an implant looks good. And also, we want to also talk about longevity. What makes an implant that starts off looking good to all of a sudden getting recession around the implant. So we'll talk about that, as well as some basic soft tissue strategies to help correct that. And then finally, we'll also talk about, what do we do with implant failures? What if we can't save an implant at all? How do we manage that site with the hard and soft tissue to get the patient a good final result? So with that, let's go ahead and get started. So this is my Instagram handle. If you guys have any questions or any comments at all, I'd love to hear them. My Instagram handle is david.wong.dds. Just DM me and I'll be sure to get back to you as soon as I see it. So one of the common themes when we talk about dental implant conferences these days is dental implant success, defining it and achieving it. So what are the qualities of an implant that make it not only, successful, but also last a long time? An argument can be made, with these implants that you see on your screen here, that they've all integrated, they're all surviving, but none of them are a success because they look terrible. The patients aren't happy. They don't look good. They don't look healthy. So what are some things that we can do to not only avoid these situations, but also treat them? So one of the first things that I like to do whenever we're talking, to beginning and intermediate, implant dentists, I'd like to talk to them about assessing risk and being able to predict tissue behavior. That way they're not surprised, when things don't always go their way. So one of the three basic things that we look at, one is tooth morphology. And with tooth morphology, the biggest tip that I have for anybody that's placing implants in the aesthetic zone is that, long tapered teeth, they're a lot harder to replace than short square teeth. So if you were to pick a case to do an implant on, you're definitely going to want to pick the case on the left side. The other thing that we look at besides tooth morphology is the smile line. So when patients smile, some of these patients can show a whole lot of gum line, right? And they have really, really gummy smiles like the patient on the left. So we want to avoid that patient as much as we can and choose the guy on the right who has a low smile line. That's going to make our lives a whole lot easier. The third thing we look at, which is not as obvious, is the periodontal phenotype. So with periodontal phenotype, we often talk about whether the tissue is thick or thin. And then later on, we'll talk about keratinized or non-keratinized tissue. But generally speaking, thick tissue responds a whole lot better to implant treatment than thin tissue like what you see on the right. So between these two cases, you're going to want to pick the person on the left. So that brings us to the issue at hand for this webinar. So complication prevention is nice, but what do we do when problems actually happen? Forget the whole prevention thing. Like these are cases where they walk into your office and they're like, "Hey, I don't like my implant, fix me." So what do you do? So this is a situation that I got dragged into this year. And this is a text that I got from a new patient's husband who happens to be an orthodontist. And what he says is, "Hey, basically, you're going to see my wife, this afternoon. Call me when you get a chance. I want to talk to you more about that." And I say, "Sounds good." Or he says, "Sounds good. Appreciate you seeing her." So that was the introductory text. But the problem is here's his wife's implant. You can see that, it's tooth number 8, obviously, front tooth. And you can see nothing but, exposed metal just glaring at you. That's all you can see when she smiles. So I ask, naturally, who placed the implant? And I call the surgeon, who happens to be a friend. And I get a text back from my surgeon friend, and he says, "Look, all I know is that when I sent her to get her final restoration, this is what the soft tissue looked like. I placed an immediate implant in an extraction site, and I placed a custom healing abutment to, preserve the tissue and help train the tissue a little bit. And this was June 2018. So my question to you all is, how do you get to this point from this point, right? How is that even possible? Because most of us, I would think that if you saw the patient, with a custom healing abutment like you see on the right side of your screen, you'd be pretty happy with that. And as a general dentist or a restorative dentist, you'd be happy restoring that. But here we are. So how and why does this happen, and what do we do about it? So one of the things that we get into in these cases, because they do involve, a surgeon, a restorative dentist, a lab, a patient, sometimes we just get into the habit of pointing fingers at each other, right? Nobody can or wants to take responsibility for what happened. We don't know whose fault it is, or if it's anybody's fault, or is this just something that happens? We don't know. So today we're going to talk about implant position, the effect of implant position on gingival recession around an implant. We're going to talk about the abutment and crown design and how that's transformed the last few years. And then we're going to talk about the qualities of solid soft tissue that's built for longevity. We're going to talk about the periodontal phenotype. We're going to talk about keratinized tissue. We're going to talk about all that stuff. So let's go ahead and get started. So when we talk about, supposedly the most ideal way for maximum implant aesthetics, the best treatment out there, like if you were to ask anybody, most people say, well, that would be an immediate implant. Take out a tooth, put an implant in, put a provisional on it. That's the best way to get the best aesthetic outcome. That preserves the hard and soft tissue. However, when we look at the data, when we look at the research, this is Dr. Stephen Chen and company back in 2009, when they looked at how often these recession defects happen in immediate implant sites, it's actually kind of surprising. In this paper, they reviewed 91 studies, and not surprisingly, over 90% of the implants survived after 1 year. That was not a big deal. Survival is not a big deal. The implants do integrate. The problem is that recession is actually pretty common in type 1 sockets. Meaning when you take out a tooth, you have 4 walls of bone with some good soft tissue to go along with it. You place an immediate implant in there, they were still seeing quite a bit of recession in these type 1 sockets. Now, they outlined some risk factors that make recession a little bit more common, and that included having a thin tissue biotype, a misplaced implant or malpositioned implant, or a thin and damaged facial wall. They also made note that patients who had their implant in a early or delayed approach had less frequency of recession than patients who had an immediate implant. And so take a look at these cases. So you have three cases right here where you have immediate implants placed, and you can tell right off the bat they don't look good, right? And they probably will not look good. So how do we get into this position, and how do we recover from that? Same thing here. We have a misplaced implant. Implants should probably come out at the time of placement, but we didn't, right? And when I say we, I mean they didn't, right? They put the implant in. They could have unscrewed it and just lived to fight another day, but they just left it in, and naturally it integrated. So sometimes we place implants in a pretty decent position and restore the implant and everything, and you still get recession. So how can we avoid that? Obviously, this is no fun, especially if this is your patient and you place the implants. So how often does this happen? So when you look at immediate implants versus early placement of implants, how likely are you to get recession on those cases? So this paper, also from Stephen Chen and company in 2014, they looked at 114 articles, and what was interesting about this paper is that immediate implants in type 1 sockets had the highest variability of recession of 1 millimeter and greater. That variability was crazy. It was 9 to 41%, 1 to 3 years after placement. So in other words, take out a tooth, you put in an implant, within a year, you get about 1 millimeter of recession, and that range is 9 to 41%. The way I read that is that's not about science or the way biology or the way tissue behaves, that's skill, right? Somebody's not putting implants in the right spot. The other thing that they noted is that 2 studies reported that the CBCT was undetectable, right? At least they couldn't see it, based on their analysis, they couldn't see it in 36 to 57% of the sites. So one of the keys to success for them was making sure that we have a nice thick tissue biotype and an intact facial wall in order to stabilize that facial tissue so it doesn't recede. So in other words, what we know so far, in this short talk, is that the best aesthetic results are with an immediate implant. The worst aesthetic results are also within an immediate implant. So you get the best and the worst with immediate implants. So what are some things, obviously there's some skill level there and some experience level at play there, but what are some things that we can do to help ourselves? So let's just remember the old adage in implant surgery, which is the bone sets the tone, but the tissue is the issue. So we need to really focus on facial plates and the interproximal height of bone. Those are the keys to aesthetics. The IHB, the interproximal height of bone, they started looking at that in the 90s after, we started to observe, tissue behavior around immediate implants. And what they noticed, this is a paper from Salama and Garber, they pointed to the IHB as being very important to ensuring that we have, good papilla height and good facial soft tissue. Because if you're going to, and as we'll see here in a minute, we'll see that having good IHB is crucial to being able to do any type of grafting. Then you go over to Dr. Tarnow's, paper about papilla height and the vertical distance of the tissue from the contact point to the crest of the bone. So we know that, interproximal height of bone is crucial, especially to papilla, but also in our ability to stabilize that facial tissue. So for the best long-term implant aesthetics, we want to make sure that our implant position is in a favorable long-term position, which is what we call the 3-2 rule, which means the implant platform is placed 3 millimeters apical to the free gingival margins of the adjacent teeth, and it's placed 2 millimeters to the lingual, right? In other words, it's placed in the cingulum area so that we can have a cingulum emergence or a screw retained crown. It also leaves, approximately 2 millimeters of bone to the facial aspect to protect against future, resorption. The other thing we want is thick tissue, specifically on the facial aspect. We also want a facial plate. We don't know how thick of a facial plate we need. We just know that we need one. And then, of course, we already talked about the importance of the IHB, which begs the question from me to you. What do you guys do when you extract a tooth? And there's so many things that we can do, keeping in mind that the facial plate and the interproximal height of bone is crucial. So one of the things that you'll see is the idea of orthodontically extruding a tooth to improve the IHB, to, sometimes for papilla regeneration, but a lot of times just to preserve the papilla. We talk a lot about immediate implants, which once again, very, very popular in the 1990s. Along with immediate implants came the idea of grafting the gap. So there was this idea of the jumping distance from Botticelli and company in 2003. We now know that I'd say most people, when we look at the papers and talk to people on at dental implant meetings and things, the majority of people graft the gap. Okay, that's just where we're at nowadays. And then we have another, huge group of docs that promote partial extraction therapy, which is another way to protect the facial plate and the hard and soft tissues. Once the implant's placed, we have more decisions to make. We have, the idea of, should we place a provisional? Should we just place a custom healing abutment? Should we just place just a generic stock healing abutment? So on the left-hand side of your screen, we're going to talk about, we're going to mention the dual zone grafting strategy here with Dr. Steve Chu and Maurice Salama, Dennis Tarnow, David Garber, and that group. They talk a lot about the dual zone grafting techniques. We can also, and if we don't want to do that, we can also add a graft, a soft tissue or hard tissue graft. Joe Kahn mentioned that strategy way back in 2005. There's also the surgical veneer graft from the Andrea and Alessandro Agnini, along with Salama and Garber, along with Richard Martin. So there's a lot of support for adding soft tissue at the time of implant placement. But if you can't provisionalize, we talk about the value of placing a full contoured healing abutment so that we can train and manage the tissue. Implant surgery also comes with a decision that we have to make. Do we do it flaplessly or do we reflect a flap? Should we use a guide or not? So these are some things that we really need to talk about if we're taking out teeth and putting in an implant at the same time. Now, for a lot of people, they're very uncomfortable placing an implant at the same time as the implant as the extraction. So they'll opt for socket grafting, right? Ridge preservation grafts. They'll talk about socket seal, to preserve that soft tissue so it doesn't collapse on us. And then I'd say a lot of people, especially when they're beginning their implant surgery journey, they'll choose for, a staged surgical approach or, late implant placement. That way, they're placing an implant in a nicely healed site instead of having to, try to target a palatal wall for an immediate implant. So the bottom line is, when we take out a tooth, there's so many surgical strategies to consider. Just think for yourself, how many of these strategies do you employ in your office? Do you have a go-to, or does it depend on the situation? For me, it depends on the situation. I would say all the strategies, obviously these are my cases that I showed you. Those are all strategies that I've employed over the years, and it really depends on the case, on what I choose to do. But what about the restorative influence, right? It doesn't really matter, how good I am or your surgeon is, or if you're the surgeon. Sometimes it doesn't matter how good of a surgery you do if we drop the ball on the final restoration. So how important is the restorative influence? Well, it's very important. I mean, you could literally drop the ball at the 1 yard line and wreck the whole case if we don't manage the soft tissue properly prosthetically. So in the old days, I would send my anterior implant cases back to the restorative dentist with just a healing abutment on it, and I would just rely on them to train the tissue and deliver a nice crown. The problem with that strategy or approach was that a lot of my dentists, they would just go straight from this narrow healing abutment to taking a final impression, and then of course the crown would come back kind of big, and they would just numb the patient up and squash the crown on. And that would be how it worked. If the tissue responded positively, we had a great result. If it responded negatively, then we just had a result like you see here, and patients weren't always happy. So at some point, we have to all recognize that in order to get a maximum implant aesthetics for longevity, it's going to take more than one person. It takes good surgery, good restorative, good lab, well-educated lab, and of course, patient compliance as well. When it comes to the restorative, I think one of the take-home points that I want everybody to make sure they get is how we've changed how single implant crowns look, from a design perspective. This slide that I borrowed from Howie Gluckman, the picture on the right is his. The case on the left is mine, but he shows very, very, I think, very clearly the difference between classic, implant crown design, where you have a convex surface at the cervical portion, to how we do them now, where they're more concave. That concave surface is really important for helping us, preserve and rebuild tissue and control, that facial gingival margin. So, when we look at crowns now coming back from the lab, we want to make sure that they have that concave subgingival or subcritical contour. Even though it's been around for a long time, in 2021, so just a couple of years ago, some friends of ours Dr. Ramon Gomez Meda, Jonathan Esquivel, and Marcus Blatz. They published a paper on this concave, crown and abutment design approach. They called it the aesthetic biological contour concept. And I won't bore you to death with it, but essentially, anything subgingival, that restorative aspect is concave. Everything's concave once we get below the gum line. So the other thing I find that we sometimes drop the ball on is impression making. So this is not an impression making course, but I can share with you what happens when we don't take accurate impressions. So starting from the left to the right, on the left side, you'll notice that the patient has a soft tissue graft and a custom healing abutment. And then in the middle here, you'll notice that we have pretty even gingival margins. So for whatever reason, from that day to the final delivery, that gingival margin on number 8 goes up. Why does that happen? It's a combination of poor impression making and also poor abutment and crown design. It doesn't matter also if you use the latest and greatest technologies like partial extraction therapy and utilize fail safes such as utilizing a surgical guide to place your implant. You can still end up with a poor result. So once again, I just want to bang home the point that to get a good final result for the patient, it takes the surgeon and the restorative dentist and the lab to come together. So what are some strategies for managing poor implant aesthetics? Let's talk about soft tissue dehiscences, or STDs. Now, STDs, that was coined, I think it was coined by Giovanni Zucchelli. I've given him credit for it. If I get it wrong, let me know. But I believe he talks about STDs first, and sometimes he calls them PSTDs, peri-implant soft tissue dehiscences. If you just wanted to call it gingival recession on an implant, I would be totally fine with that. So how common are STDs? So when we look at it, the data on it, this is from Tavelli, and you'll see Zucchelli's name on this as well. But this is as recent as 2021. And when they looked at prevalence and risk indicators for recession around implants, this paper, they looked at 176 single implants, and they noticed that 100 of the 176 implants had recession on it. That amounts to 57%, right? And then 43% of the implants did not have recession. So in 176 implants, more implants than not had recession. The risk factors that they outlined was that the longer the implant was in service, the more at risk they were for having recession. This is looking at 9 years versus 5 years, okay? They also noted that implants placed right next to each other had a higher risk of recession. They also looked at the lack of bone, the thin facial tissue, and less keratinized tissue or less keratinized mucosa, which is a little bit of a newer concept. All 5 of these things were responsible for STDs around implants. There are some limitations of the study. It's not a perfect study. There is some subjectivity in observations because, how much is recession? Is that 1 millimeter? Is it no millimeters? But the other reason that there are some limitations to this paper is that they didn't, none of the patients had any type of soft or hard tissue augmentation at the time or around, implant placement. And they also didn't look at how deep the implants were placed. So we don't really know that effect on the gingival margin either. However, there are some strategies that they talked about in order to limit facial bone loss and recession. We've talked about all of these already. The biggest thing was place an immediate implant if you can. To do even better than that, place a provisional if possible. To do even better than that, supplement that immediate implant placement and provisionalization with a soft tissue graft. We call that a surgical veneer graft. And then if you get into it, if it's your thing, you can do partial extraction therapy where you leave the facial part of the root intact and attached to the facial wall. And that way, the hope is that you preserve that facial plate, and you preserve that interproximal height of bone and the soft tissue, that natural soft tissue drape and scallop that goes along with that. Finally, we're definitely changing the way we do our crown designs. We're paying a whole lot more attention to the subgingival contour and the emergence profile, making it concave when it comes to the subgingival aspect. So the bone sets the tone, but the tissue is definitely the issue. So let's look at some cases here. So this is a young lady who came to us because she was unhappy with her implant, which is obviously tooth number 7. She does not like how long the tooth is, and it kind of just throws her whole smile off. But before I get into how we treated her, I kind of want to give you a little bit of insight into how I approach these types of cases. When I'm preaching, goals and expectations to my patient, my first goal to them is I want to get them healthy. So if there's like gingivitis around the implant or active bone loss or something, I want to make sure that they get healthy first. And then I want to make sure that we get them comfortable and functional. And then if we pay attention to getting them healthy, getting them comfortable and functional, usually I have discovered that the aesthetics is a natural result of that. And this is also said very, very well by my good friend, Christian Coachman, who says, aesthetics shouldn't be a priority, but yet a beautiful consequence of the proper treatment. So going back to this case, you can see how having a lateral incisor implant that's so high up in her gummy smile, it really just throws off her whole symmetry of her smile. It just does not look good overall. So when we look at this case, you'll notice that the facial contour is a little bit, it's over contoured on the facial aspect relative to the other teeth. But when you look at this case, you look at it, the x-rays, you look at the CBCT, you're like, man, it's not even that bad, right? The implant's placed straight directly in the bone, evenly between the two adjacent teeth. There's no bone loss around it. So, what do we do? How do we manage this? When you look on the left side, her tissue's a little bit inflamed, but nothing too wild. But before we get started, I have to ask myself some questions. Is there a facial plate? Well, if you look backwards, yeah, there's a facial plate. How's the interproximal height of bone? Well, it's good. Looks really good. Tissue thickness is okay. It's not thick. It's not thin. I mean, it's good. It's good. The tissue is keratinized. There are papilla. They're narrower papilla than the other contralateral teeth. How's the prosthesis design? I'm going to go out on a limb and say it's poor, right? And the overall smile, she overall has a gummy smile, right? It's a combination of altered, active or passive eruption, but she definitely has vertical maxillary excess. So there's no fixing that with just periodontal gingival surgery. And then, how much is all this going to cost to fix, and what are her expectations? So I can tell you, her expectations are very not too bad. Not too bad. She's not a particularly picky person. As a matter of fact, this implant's been in place for 7 to 8 years. So it's not like she's done anything about it till now. So she's got good expectations. She just wants it to look a little bit better. So the question I have is for you at home, but for me, especially since I'm treating her, are you in or out? And I chose to be in. And I will say this, though, when it comes to treatment options, when I ask people what they would do with this case, the treatment options usually kind of go into two different directions. Group one will say, remove the implant, just take the thing out. Group number 2 would say, well, just decoronate it. And what decoronation means, just take the crown off and put a cover screw on it and let the gums heal back over and then start over from there. I think either one of those treatment options I wouldn't argue with. They're not for me and what I chose to do. But one quick reminder that I always tell people is that hope should never be a strategy. You should never have to cross your fingers and then hope something works in order for you to be successful. So my personal goals is I want to be as practical as possible, because understanding that patients go through a lot, from the time that they have an implant extracted to the time that they have it replaced and restored, they've already gone through a whole lot of stuff, especially if they went through that staged implant approach. So for me, I wanted to help avoid going back to a removable prosthesis like a flipper or an Essex retainer. I didn't want her to have to go backwards and do that. I also wanted to minimize the number of appointments. I didn't want to do a bunch of surgeries, in other words. And then I also wanted to minimize her pain, because I didn't want her to have to, I didn't want the cure to be worse than the problem. So one of the things that we did is we worked with the lab, and this was the abutment design that they had for her. And those blue marks are from me and my Sharpie. I just told the lab technician, I said, wherever I mark it, just shave it all down. You want that facial surface as flat and concave as possible. Okay, I can't state that enough. Where this comes from is from Goldstein and Vafiatis. They wrote a 3-page paper that basically, in a nutshell, says for every millimeter you take the abutment in horizontally, you gain roughly about a millimeter of tissue height back. Okay. So this was the abutment that she presently had in place on the left, and then this is the modification, a new abutment on the right. So when we did the surgery, we took the crown off first, and then we took off the abutment. Okay. Once we took off the abutment, you can see how facial that implant position is. So that was, that's an issue unless you want to just take the implant out, which I did not want to do. So I chose to fix her by, number one, changing the abutment design, making the subgingival contour more concave. And then surgically, I chose a tuberosity connective tissue graft, because I wanted a nice thick graft without hurting her that would stay in place. And what we know about tuberosity connective tissue grafts is that they have a lot of fibrous tissue in there, very high percentage, not a whole lot of fat and glandular material. Doesn't hurt in this area nearly as bad as it would if we went to the palate. And you can get a lot of volume. So the rare downside is that sometimes the tissue grows too well, and it keeps growing back. But I personally have not seen that happen. For more information, here's another. You can hit pause and check out this paper about tuberosity grafts. But in that video on the left side, you can see how thick that connective tissue graft is from the tuberosity. What you need to do at this point is take either a round diamond or just a fresh 15 blade and shave off the epithelium. That way you can utilize that connective tissue underneath your existing flap here. So here I've made a tunnel flap, utilizing the freedom as my tunneling entry. And then on the left side, we did some crown lengthening to kind of give her a little symmetry, so we could also fake it in case we couldn't grab or graft all the way down and make number 7 totally normal. So here's the abutment, and then we've released that tissue through that frenum attachment. So that was my tunnel approach, utilizing the frenum. And then we used a sulcular approach on the other side so that we could crown lengthen the teeth and reduce the bone so that the tissue stays lengthened. This is what she looked like when she left the office that day. This is what she looked like 3 weeks post-op. You can see on the right side, look how thick that facial tissue is. And then here we are still at 3 weeks post-op, looking beautiful. Here we are at 8 weeks. Things are still looking pretty darn good. There's our before. Here's our after. And here we are. It's finally done. So what I like about this case, I mean, the result, I think, speaks for itself. It definitely looks a lot better than when she started. But what I love about it is that it was practical. I mean, it was a tuberosity graft, one surgery that took about 45 minutes. with all the, putting the crown back on and all that stuff, maybe an hour. It was relatively painless and it was very predictable. I think once we learn more about prosthesis design and tuberosity grafts and flap designs, proper flap designs, everything like this, is actually pretty predictable. It can be pretty amazing, when we talk about how dramatic the change is. The flap design, like I just mentioned, it is the key to success. So when you have a case of a failing implant that's failing cosmetically, it's really important that we abide by a few rules. One is papilla preservation. So don't reflect the papilla. If you reflect the papilla, you run the risk of losing that papilla, which would compound the problem of the recession on the implant. You want to make sure that you have tension-free flap so that you can have access and space to the implant and root surfaces so that you can slide your graft in without, having too much tension and pressure. This type of a design where you tunnel through the frenum, it also has the benefit of not, minimizing the chances of tearing the flap or perforating. Where the flap design for this last implant case came from, I borrowed it from my own flap designs when I do root covered surgery. And I don't know who invented the flap design, but I can tell you, I'm the one who named it. And this is what we call a frenum access that I'm going to show you here. So here we've got, soft tissue surgery to treat the recession on number 5, 6, basically 5 through 12, but the worst teeth are the canines and the premolar, and number 10. So if you want more information about this flap design, it's in Inside Dentistry, September of 23. And it's called the frenectomy anterior tunnel sulcular access channel approach. It's, like I said, it's in Inside Dentistry, September 2023. And the reason we call it that is it's a frenum access. So that's how we tunnel. Instead of tunneling through the sulcus like a lot of people do, we tunnel through the frenum. We do an anterior tunnel so we don't accidentally, pop the papilla or lose the papilla, especially when we're trying to work on a front implant. The sulcular access channel is important because we will reflect the papilla there in order to get access to the abfractions in order so that we can treat the root surfaces. Now, I've called this fat sac for short. It hasn't caught on yet, but I think it will. But anyway, it's the frenectomy anterior tunnel sulcular access channel, or fat sac for short. And anyway, whenever you have these long grafts that you have to place over the recession defects, tunneling the traditional way can be kind of difficult. So that's why I think going through the frenum in the middle and a sulcular access in the back enables us to get that graft in there, safely and easily, so that we can suture up and get the patient a nice, beautiful result. So remember that term, fat sac. That's the flap design. And like I said, it's borrowed from a lot of different people. I'm totally tongue in cheek with the name, but it is something that we just published this month. Anyway, looking ahead at another case, very similar to the last one, not as bad, but we do have the added, marginal inflammation that you can see on implant number 7. And the same thing that caused the last case with the poor crown design. It's same thing here. Poor crown design, poor implant position. So it can definitely be fixed. It's not super hard, but unlike the last case, this case has a different expectation. When you look at how small the papilla are around number 7, pretty tiny compared to the papilla around number 10. So you have to tell the patient, I can bring the gum line down on the facial side, but the papilla, that's going to be about the same. So when you pull the crown off, you can see here that we have a very convex crown surface on the facial aspect. So that's got to change. So when we make a provisional, we want to make sure that we have the subgingival contours are concave, right? This is what we talked about with the aesthetic biological contour concept that just came out in 2021. Okay. So just like the previous case, I also like to use a tuberosity graft like you see here. And that's what it'll look like. Quick reminder, you got to make sure you de-epithelialize that, take the tissue, the skin off of the tuberosity graft so that you're left with nothing but connective tissue. I do that with usually a fresh, 15 or 15C blade. And sometimes I'll use a round diamond burr. But anyway, it's going to go through the frenum anterior tunnel. And then this is what you'll notice at 2 weeks post-op. You can see the tissue's grown down a lot. The papilla still kind of small, like we knew they would. So this is at 12 weeks and then 2 years with the final restoration. So overall, not a bad result. When you look at the occlusal view, nice, thick, pink keratinized tissue, a lot of tissue. This is what she looks like when she smiles. So this is how it started, and this is how it's going. Malpositioned implants in the aesthetic zone, that could be a different thing. Okay, so far we've done pretty simple cases. We've changed an abutment design, done a little tuberosity graft, no big deal. Sometimes we get into situations like this here, where what was a tissue management problem, now we're doing more of a rescue mission, right? We're not managing anything, because remember earlier when I said hope should not be a strategy. Well, with these rescue cases, unfortunately, hope is a strategy, and I hate that, but there are definitely going to be some things in this case that I'm about to show you that are beyond our control. So here we've had a patient. He had 2 implants placed for number 9 and number 10, which are 2 very, very challenging teeth to replace, even when things go right. But when things go wrong, like they have here, boy, it can be really, really difficult. This is his smile line. Look how high his smile line is. So right now, you can't really envision, at least I couldn't at the time, I couldn't envision how the crowns would look, aesthetic. Even if you did pink ceramics, I don't see how that's ever going to look good. So when we evaluate this up close with the lips retracted, you can see that there's no keratinized or attached gingiva on the facial of the implants. You'll notice that the papilla between the implants also non-existent. Matter of fact, you even have a negative papilla. The interproximal bone heights on the number 8, number 11, they actually look pretty good, but our challenge is going to be that area between the 2 implants. So how do we get that much volume? In this situation, I'm not going to go into too much detail, but you're going to have to do some heavy gum grafting here. And I used a technique that's called the vascularized interpositional connective tissue graft. And that's how you're going to get the most volume that's going to stay around the longest. The reason why 2 implants next to each other, are so hard aesthetically is the papilla between 2 implants. This is a paper from Salama and Garber and Pincus Adar. It's kind of old, 25 years old now, but what they observed was, between 2 implants, the papilla height on average is only 3.5 millimeters tall. Whereas if you go implant and pontic, and you'll see that strategy sometimes going implant pontic, that papilla height goes from 3.5 to 5.5 millimeters, so you can get quite a bit more, and you're kind of just faking it with prosthetics at that point. But if you go implant pontic, that's even better. So obviously we can't always do that for occlusion and parafunction purposes, but when you can, try to avoid 2 implants next to each other in the aesthetic zone. So with the flap reflected, there's no interproximal height of bone between the 2 implants. So I had to get a little aggressive, with the soft tissue. So here I chose a graft that's called once again, the VIP CT graft, vascularized interpositional connective tissue graft. Doesn't sound as cool as fat sack, but that's okay. When you look at this, you can really see the benefit of doing 2 of these grafts, one on the right, one on the left, and folding them over the implants. I'll keep the healing abutments on. Okay, that way they'll give me a little extra height. and then we'll suture them in place, coronally advance the flap, and let's watch it heal. Once again, the advantages of the VIP CT graft is to maximize volume and provide less shrinkage. We want to stay around, and because these grafts they hang on to their blood supply, we don't harvest the grafts, take them out of the mouth, and then put them back in. We literally just flip them and fold them over the recipient bed, so it maintains its blood supply. Therefore, it maintains its volume. So here we are all sutured up, and then here we are 2 weeks later. Things are healing up pretty fast. There's only one little area of necrosis, which is right on the mesial of number 8. Here we are at 8 weeks. And with connective tissue grafts like this, when you pull all that mucosa over, you do get the volume, but you also get a little bit of redness or discoloration, like you see here. So the patient was also, complaining about how he has kind of a lump or a convexity of soft tissue, right lingual to the central and the lateral number 9-10 area. So because he also is deficient in keratinized tissue, he has good volume, he has good thickness, but the keratinized tissue looks terrible, especially if we're thinking about doing any type of crown lengthening to address his gummy smile or the short square teeth. So we ended up utilizing that tissue that he was complaining about, and I utilized it in what I jokingly call the Oklahoma graft, and we placed it over the mucogingival deficiency so that we can build up some more thickness and keratinized tissue, and here you are. So the benefit of this is that now we have a better color change. It's more pink, it blends in a lot better. So now when he smiles, this is his before, and here's the after, but now when he smiles, you can see that that tissue matches way better, but you can also see his smile is crazy gummy. I didn't like that. So fortunately, by the time his dentist sent me a final photo of him, he had done a little bit of a gingivectomy to get those teeth a hair longer so that his smile is restored. But anyway, you can see everything's looking beautiful. He's looking great. This is at 4 years. So I anticipate this to last a long while, but with implants, who knows? But we look good right now. So what do we do when we have just a complete, failed implant site? Like it just didn't work and we got to start over. Well, one thing I can tell you about myself, I don't like to twist implants out, when they have 4 walls of bone around them. I don't like to cut them out. I'm just I hate removing implants unless they're just grossly misplaced. So in a situation like this, you can see that this patient's developed a soft tissue fenestration on his implant number 9. And when you look at it on a PA, everything looks pretty good, but on a CBCT, you can see everything's on the facial. So taking out this implant was like no problem at all. It's just simple, elevator and you pop it loose. So the question here is, how do you time your surgery? Once you take the implant out, do you do your bone graft first? Or do you try to do any grafting? Or do you let it heal? Do you do a soft tissue graft? What do you do? My preference is whenever we take out an implant and we know we're going to need some soft tissue work, like it's obvious here, when I take out the implant, I'll go ahead and do a graft at the same time. In this situation, I did a free gingival onlay graft, and that's going to come from the palate again. But I like these types of grafts because it saves the patient another surgery. And if it's going to hurt, you might as well do it now. So we take the graft from the left side of his palate, transplant it over to the facial aspect, and you'll notice that at 2 weeks, the graft is looking pretty good. We let that heal up 3 full months, and then we'll come back and do the GBR procedure. So, or ridge augmentation procedure. You can do whatever you want. I chose GBR, but at any rate, you can see how narrow his ridge is. All his bone is on the lingual between 8 and 10, but not very wide. So I utilized a tenting screw for my stability and my space maintenance. And then we used some autogenous bone mixed with PRF and some allograft and xenograft for a nice composite bone graft. Then I placed it on the facial aspect, covered it with a membrane, and closed. This isn't exactly a GBR talk, but suffice to say, the soft tissue is necessary in order to get good tissue to cover our defect site with. You want thicker skin anyway. That was the ultimate goal. So now you do it now and not have to do it later. Also, every time you touch tissue surgically, it tends to want to keep getting thinner. So doing a free gingival graft early on, I think helped that tremendously. After 6 months, we went ahead and took a CBCT and a scan and all that stuff. So we're planning our surgical guide so that we can place our implant. And here you'll notice that I replaced, I did a full flap. I don't know why I did that. I usually don't. But anyway, if I had to do it again, I'd probably just go flapless. Implants placed. The scan body was placed as well to take an impression. And the point of that was so that we could have a provisional ready by the time that we uncovered the implant. On the right side, you can see the patient fortunately has a very low smile line. And there he is 3 years post restoration. So crowns don't look the best or perfect, but they look pretty good, you know, especially when you consider he started from here. So we have a few take-home messages here. And so the first thing here is if you don't want an STD, a soft tissue dehiscence, you want to choose a case that fits your ability. You don't want to get into these complex cases that are over your head. It's something that you can do, and you've had good experience and feel good about it, tackle it. But make sure that your case fits your ability. Tip number 2 is when you place your implant, don't go too facial and don't go too shallow with your implant. Remember that 3-2 rule that I mentioned at the very beginning of the talk. You need facial bone, so be sure you do whatever it takes to preserve or restore that facial plate. And you're only as good as that IHB. So remember how I was talking to the patient about the expectations for papilla heights. If you have interproximal bone loss, don't be promising people, you know, nice, full, big, plump papillas, because that's probably not going to happen. So finally, the tissue is the issue. You want thick and keratinized tissue whenever possible. What do you do if you do get an STD? Well, you have to figure out if you want to save or remove the implant. If you choose to save it, you got to set those expectations. Remember, hope is not a strategy. Let them know exactly where, you know, if they're going to get an aesthetic improvement and whether or not that aesthetic improvement is going to be enough to satisfy them. You got to talk in terms of, you know, where the facial gingiva is going to be, in terms of where you have to speak in terms of where the papilla are going to be. So be sure to inform your patient properly. Go back to the provisional stage whenever you can, preferably one that does not come in or out. So no flippers or Essex retainers if possible. That's just my preference. It's not a hard and fast rule, just my preference. But remember the aesthetic biological contour. Any part of the tooth that's subgingival should be concave. And then autogenous tissue is king. You want to make sure that you use the patient's own tissue and not, you know, some type of an allograft. Allografts work great in some people's hands, but I would say that on average, everybody does better with autogenous tissue than they do versus a soft tissue allograft. And finally, be patient. You know, soft tissue does heal fast, but if we want to try to grow things and to change, literally change, you know, periodontal phenotypes and biotypes, that takes a little while, you know, so be patient. But whatever happened to the orthodontist's wife? So remember, she came in like this with all the metal, you know, exposed in her smile, which was just awful. So what do we do here? So remember what we talked about with the aesthetic biological contour. The problem with her case is that her implant is a tissue level implant. So we don't have the nice platform switch. We don't really have the ability, you know, to make a super concave abutment. That's not possible because the implant platform is so darn wide, right? Your only other option would be to shave the actual implant, which, you know, I don't feel good about that. I haven't done that, but I've done it once, and it was on like a 90-year-old woman, you know, so I don't want to do that. on my orthodontist wife. So the question is the aesthetic biological contour concept even possible here? You know, it's kind of possible, but not really, you know, not when you're stuck with the implant design. But when you look at her CBCT, look at that sagittal view on the right side. I mean, that implant like occupies the majority of her alveolar process there. I don't know that you want to be, you know, trying to remove that implant. Here's a closer look at it. Yeah, there's a facial plate on the facial and lingual aspect. So that's, you know, it's not like she's got a blown out facial plate or something. She literally just has very thin bone and thin tissue, you know. Just to make things a little bit quick, since we've done cases like this before today already, I chose the fat sac flap design. I freedom access. I went tuberosity graft. I did an anterior tunnel, and I chose a sulcular access channel. So I did the fat sac because I wanted to crown lengthen number 9 a little bit, you know, not go wild and expose the CEJ or anything, but just a little bit so that we can try to get a little bit more symmetry between number 8 and number 9. Talked about a tuberosity graft, and then we want to provisionalize first. So unlike the other provisionals where you can take the old crown off and make a, you know, a nice concave abutment, you can't really do that with a tissue level implant. So this is the provisional. Tissue's still inflamed on the facial aspect, but here we go. We're going to do freedom access. So we're going to have an anterior tunnel, sulcular access channel so that we can get to the facial plate of number 9. So we can recontour and reshape the bone when we lengthen that tooth. The connective tissue graft is coming from the right side of the tuberosity. And there you go. We're going to place that graft through the frenum and then secure it with a chromic gut suture, and then advance the rest of the primary flap and also secure it with chromic gut suture. Usually I use 5.0 PGA or 5.0 Vicryl, but for whatever reason today we use chromic gut. 2 weeks later, the tissue is healing beautifully. Obviously a little bit inflamed, which is pretty normal for these types of situations. But now, what did I say? You got to be patient. So we're going to wait. And with her husband being an orthodontist, he's put her back in braces for the lower arch. So we're at 20 weeks now, and we're still waiting on ortho. But once everything's done, she'll get a final impression and final restoration, as you can see here. So not too shabby, considering this is where we started, and this is how it's going. So to be continued. Let's see how this pans out. I'll give you guys an update in future talks. So once again, if you need me, give me a call or message. Instagram's probably the best way for me, david.wong.dds. Thank you guys so much.